All right. Jessica, I know you're going to keep letting people in for me while we're here or for this session, but good morning, everyone. My name's Jillian Grant. I use she, her pronouns. I'm the moderator for this session for the 2023 Culture of Data Conference. Thanks for joining us. And I am also joined by Jessica Stoker, who uses she, her pronouns. She's managing the Zoom and making sure our tech is running smoothly. You all are muted, and if you have a question, save it for the Q&A sessions after each presentation. You can also use the chat box if you have questions, and we'll get there when we get there. So if you're comfortable with adding to your Zoom name your pronouns as well, we'd appreciate that, but no pressure. And you can do that by clicking on those three dots right by your little box and renaming yourself. This session has been sponsored by Champ Software. Thank you so much. And we're joined by David Smith. So I'm going to pass it to him to share a little bit about Champ Software and their sponsorship. So thanks.
I'm going to share my screen here in a minute. Yeah, my name is David Smith. I am with Champ Software and have been working with local public health departments. Really close to the topic of today is helping local health departments get their data, basically when the silos that they're using don't give it to them. The name of our company is actually an acronym for Community Health Agency Management Program. And our philosophy has been comprehensive agency management for 37 years. One of the things I always like to ask when I'm doing a presentation, and you can't all answer me because there's several of you in the room, but look at this and slide and decide where you think your agency's at, somewhere between the Florence Nightingale era of 100 years ago, coming through spreadsheets back just before 2000 and data silos, something we're talking about today. And then where we're all supposed to have arrived 3 years ago was Public Health 3.0. Where are you on that continuum? And if you're where the blue arrow is, you're along with about 95% of the public health departments that I work with. I want you to know where we are because we built technology back in 2011 to handle all the technical requirements to support the goals for Public Health 3.0. And we just want you to know that we are Public Health 3.0 ready, and we can help accelerate your advancing towards measuring and impacting health equity. Our philosophy, like I said, is comprehensive agency management. We believe that you need to track and manage all activities with clinical evidence-based outcomes for clients, whether those are individuals, households, non-family groups, or the community at large, and even systems level impact. A lot of people come to Champ or they come to our website looking for a point of care electronic health record, and we certainly have that included. In fact, ours is unique in that we have social determinants of health built into the nursing language. We also have the ability to produce child growth charts based on the WHO and the CDC percentiles, and we offer 3 levels of documentation, but that's only one part of the system that we offer. The EHR is just one part. Data management is something that we have had as a major focus for several years, and that's what people come to us for. There's a lot of data outside of an EHR, like grant funding tracking, program statistics, population outcomes, and those kinds of things. And we have a lot more to offer as well. We are in 13 states, 10 of them are in the Midwest. We have 3 states around Colorado. We do not have our first customer in Colorado yet, but we're working with several counties there. We can collect data from all of your different programs, whether they're community health initiatives, walk-in clinics, reproductive health, school-based health, any of those. Our current clients, 170 counties, are keeping track of all their encounters and all the data surrounding that in 80 different public health programs at this point in time. We really believe it's important to move from quantitative data to actionable data. We have to move from collecting data to using that data, and we have to convert that data into information, knowledge, and wisdom. This is a couple of quotes from our users. It provides real nice information I can get funded with. It shows the benefit of our public health programs so we don't get left behind. In other words, we don't lose our funding. And this one, back from 2011 even, was collecting things in smoking cessation, depression assessment, safe sleep, birth weight of babies to get documentation needed to become accredited as a public health department. So the bottom line is we want to give you back actionable data displayed in 100 different ways. that helps you write your own success story. We offer 3 different packages with the features that are listed there. And if you want to contact me or our company, there are links there. They're also in the chat box. And so you can reach out to me to learn more than I could give you in 3 minutes today. Thank you for this session, and thank you for listening.
Thanks, David. This fits really nicely with what I believe our presenters are going to present as well, and just some overlap in themes there and tools that we can utilize. Thanks, David. So for everyone here, we have 2 presentations. Each presentation is going to be 20 minutes with 10 minutes of Q&A afterwards. And again, if you have a question, feel free to enter it in the chat. We'll get to that when we get to the Q&A session, or you can ask it out loud when we get there. The theme of this session is technology solutions to help break down silos, which I'm really excited to hear about. And our first presentation is the rapid identification of cases among priority populations using electronic lab reports and known addresses of interest. And Nicole and Julia, I'm going to have you all take it away. I'm setting my timer for 20 minutes and we'll get to Q&A after that. Thanks.
Thank you so much. I'll just go ahead and share my screen. All right, are we good to go?
I think so.
Okay. All right, good morning. My name is Nicole Turvey. I am the COVID-19 Data Analytics Team Lead at the Colorado Department of Public Health and Environment. And I'm joined today by Julia Aiken. You can introduce yourself as well.
Yep, my name is Julia Aiken, or Jules. I respond to all JUL variants, and I'm on the integrations team in the surveillance branch here at CDPHE.
Yeah, and today we're going to talk to you about the rapid identification of cases amongst priority populations using ELRs and addresses of interest. But of course, nothing in public health happens in a vacuum. And so we really wanted to give some special acknowledgement to Ty Harlow, who's actually on the call today, Shelby Lineberry, Eduardo Gabrieloff, and Rebecca Johnson for their contributions to this process as well. So to give you an idea of the scope of this project versus the COVID-19 cases that were coming in at the time, it's about a 6-month-long project from the first idea, the inception, to the actual liftoff of this program and getting it into the hands of folks who can do things with the information that we're providing. So in December, we started to discuss, based off of this original bump, whether or not we should start prioritizing who we call when it comes to contact tracing and investigation. Of course, we all know the Omicron surge certainly sped up those conversations. And by February, the CDC was recommending that formally. And by May of 2022, we were actually able to deploy some of the first pieces of this particular project. So the specific sort of guidance given to us from the CDC for case investigation and contact tracing happened on February 28th of 2022. Like I said, we were already thinking about this. And they were saying the health departments should prioritize specific settings and groups at increased risk. And I think the first question we all had was, how do I know that this person is a person at increased risk if I don't call them and ask them more about their background? Thus began the idea of gathering addresses of interest and comparing it to the addresses that we got with the electronic lab reports that are coming in. So this became a very collaborative process. We wanted to make sure that local agencies and state agencies were represented in the stakeholdering of this process. So local agencies were able to submit their lists of addresses of interest. This was really important because the way that a long-term care facility might show up on a Google search for address might be different from the way that they're submitting their electronic laboratory reports. And because our local agencies have free and easy access to this ELR data, they're very intimately involved in what addresses are being used, what addresses of interest they have, and what specific categories they're most interested in looking at. We also had some really wonderful state agencies who collaborated with us Our healthcare facilities folks were able to give us a list of healthcare facilities like hospitals, long-term care. And then our environmental health folks were able to help us with correctional settings. And then we thought, well, we should just analyze the data ourselves as well. So we looked at any specific address that had greater than 10 positive cases in a 28-day period. We then deduplicated that against the list of addresses that we had already sourced, and we wound up with around 3,000 addresses of interest across the state. And so then the next question we had to ask ourselves is, how do we turn this list of 3,000 addresses, which I don't think we ever thought it would get that large, into an actionable data set? And we started to categorize and organize. Then we needed to match them back to the ELR addresses, and then make that data accessible and think about who we're sharing this data with. So for the categorization and organization, organically, we wound up with about 6 different data sections or categories. So we have our care facilities, our correctional settings, our persons experiencing homelessness, congregate living, increased risk medical settings, and this category of other. And a few caveats I want to make here is that for persons experiencing homelessness, when it comes to data equity and health equity overall, a person experiencing homelessness is not likely to pick up a phone, not likely to have a phone number. So the ability to automatically gather their address as they come in, mark them as a person experiencing homelessness, know which shelter that they frequent because that's likely the address they put down. We can work with the shelter on outbreak intervention and make sure that that person has the resources that they need at both the state level and at the local level. When it comes to disseminating this information, which we'll talk about later, I did want to make a few caveats, and that is we do need to be careful about how we disseminate this information. If you notice, there are a few categories that might be a little too sensitive to place in a case database system or to export externally for any reason. So one of them being other migrant housing and employment, and then of course, domestic violence shelters. So we have to take special consideration to that whenever we export it into our systems, and sometimes overwrite it and rename it. So something to keep in mind when you're building a list of your own. And with that, I'll hand it over to my colleague Julia to tell you more about how we match these events in electronic lab records.
Yeah, thanks, Nicole. So now that we have gathered all of these facility addresses, we need to get them matched up to patient addresses. And to do this, you can hit next slide. To do this, we use the functions unique to the Postmaster package for our studios. And I really encourage everyone to check out the documentation for this package on GitHub, since it has a ton of cool features that we won't even get to all cover today. So next slide, please. So before we get into the finer details of address matching, I want to establish a shared vocabulary on what makes up an address. So I just used the example of CDPHE's address, 4300 Cherry Creek Drive South, Denver, Colorado, 80246. So in a database, you could have a field where the address is captured in one long string, like it kind of appears here, but more likely you're going to have it in about 5 different fields. For example, address 1, that's going to have the street number, street name, street suffix, and maybe a directional suffix or prefix. You'll have address 2, which could capture apartment numbers, suite numbers, unit numbers, any kind of additional text information. Then you'll have the city, state, and zip code, right? That's about 5 fields. And with the Postmaster package, you can take either those 5 fields or an entire string like this, and it's able to recognize these subcomponents and parse them into address, city, state, zip code, and even take that address field itself and parse it out further into street number, street name, street suffix, directional suffix or prefix. Next slide. So if Postmaster is capable of slicing and dicing addresses, how did we go about the actual matching. So I want to just take a look at these addresses below and kind of consider the differences we're seeing between each of these. So for example, in the first one, it has a directional prefix on the left-hand side, but not on the right-hand side. That can get left out. Although if you pop either of these into Google, it will still identify it as Chuck E. Cheese. Addresses have a ton of abbreviations. So we have street versus the full word for street, W versus West, Colorado versus CO, all these abbreviations. And then with zip codes as well, some zip codes have an additional 4 digits at the end that can be very even more specific within that geological region. You also have to be considerate of uppercase, lowercase, proper case, and then even the use of special characters like tildes or like the enye over canyon, right? So with all of these differences, if you wanted to standardize across all of it, that represents a lot of small decisions that you could make. But if we wanted to be smart about this, you can hit the next slide. We can also consider everything that these addresses have in common that require the least amount of standardization. So for example, the street numbers are all the same. These street names are pretty consistent once we choose a case format. And then zip codes are still able to identify a city and state without having to standardize those. And you just need to make sure that it's all the 5 digits instead of maybe 5 plus 4, right? So very few standardization decisions. Make sure you clean up zip codes, potentially remove apartment, suite, and unit numbers from the first address line. Choose a case. We went with all uppercase, for example. And then Postmaster is able to parse these out. And we took what is consistent between all these addresses and formed a matching key. So for example, that Chuck E. Cheese address turns into 5156 Academy 80918. And compared side to side, they'd end up matching up. You can go to the next slide. Is this you, Nicole, or is this me? It's me. Okay. So we want to show y'all how we ended up matching all of these and made it usable for not only our contact tracing team, but at the local level as well. You can hit the next slide. So this is Dr. Justina, our contact tracing system, and patients that matched up to one of our priority addresses ended up in a priority hub. We only filtered in cases in here that were hadn't been interviewed yet. So once it's interviewed, it gets out of the hub. And as soon as you click on their case, this is SpongeBob. He's not likely to get COVID. He might have SUDS. But it shows a synopsis of why we consider him a priority to be investigated. This is a snippet of our surveillance system, CEDRS, for Mermaid Man. Obviously not a real person, but we used address matching to additionally kind of buffer the completedness of our institution fields. And it really, Nicole will talk about it later, but it really demonstrated an improvement in our completedness. Next. And lastly, we also made this information available in our LPHA portal, local public health agency portal, where they can download an Excel exported file of ELRs that match up to not only a facility, but also if we consider them a priority due to their age, such as being greater than 50 years old or maybe less than 5 years old.
Thank you so much, Julia. So this might seem like a simple process and a simple project, but it did take 6 months, and it actually, for the most part, was really a revelation to our data. It had a giant impact on our processes, the way we think about our data, the way we think about contact tracing and investigation, and the way that we want to move forward. So I'm going to talk a little bit in numbers and also pie in the sky of what the impact is and can be. So it did greatly improve our data quality and resources utilized. So as Julia alluded to, we were actually able to detect a case's residency in an institution from 3.4% of cases to 36.9% of cases in December of 2022. Huge jump. We were also able to give some reprieve to our CICT staff who had been working a very hard pandemic. And so we were able to increase their interview rate and completion rate up to 9%. Or it rose by 9%, and then the refusal to interview dropped by 10%. So great for resiliency for those folks. And then our analysts and our epidemiologists were able to flag and detect cases and outbreaks in settings before a single phone call was made. So without CICT having to operate, they were able to quickly identify outbreaks and provide more cases for CICT to look at eventually, but we'll talk about that in a moment. So this really is a resource and equity conscious approach, and it's one big circle, the circle of a case really. So you have an ELR address coming in, we're gonna match it to this address of interest several times per day, put that into our data systems, our Dr. Justina case investigation system, our CEDRS case database system, and also our local public health agency free access data portal. And then our CICT process occurs. Staff members within CICT are able to make these really wonderful decisions about who to call first, who might need resources first, and they can prioritize. If, let's say, we have an Omicron surge and they can't call everybody in a day feasibly. So this means that they're able to call the people who need it most first, perhaps create additional cases and contacts. And then we have this nifty feature, which is outbreak detection. So perhaps even before CICT gets on the phone, an outbreak investigator can know that there is an outbreak at their local shelter, and they can start logging contacts, they can start logging sort of the web of contact and the way that this disease is moving through that population. And with that means more testing and more electronic laboratory reports coming into our system, and we start the process all over again. So it really creates this wonderful resource approach, resource conscious approach, and also helps us with health equity, because now we're focusing on the populations that we should be, instead of messaging to general members of the public who might already have an idea of some of the public health messaging that makes the most sense for them. So in terms of future possibilities, there are many, but we're going to talk about a few today. In terms of what's next, we are using this addresses of interest process. And what we're doing with it is it's an editable table. So counties can come back to us and say, we'd actually like you to change this address or add this address. Our own analysts can add addresses as they see fit. Our internal agencies can add and take away addresses as something closes and opens. And it also allows our analysts to give further context to both past data and current data for how this virus moved through these special populations. And as we transition to a new surveillance system this fall, this system is in the talks to be used to flag all of our cases in priority settings for all communicable diseases, so outside of just SARS-CoV-2. And then it also allows us to very rapidly identify potential outbreaks in high-risk settings. And with that, I thank you for your time. If you have more questions about this process outside of the Q&A today, please feel free to reach out to myself and Jules. We're happy to talk about data with anyone who will listen. So reach out if you like.
Thanks, Julia and Nicole. Awesome. And you're under your 20-minute presentation time. We'll open this up for 10 minutes of Q&A. Folks, please feel free to unmute yourself, or you can enter your questions in the chat. What questions do folks have for our presenters?
Thanks, you guys. I have a question. This is Mike Barbie. I work over with the West Mountain Regional Health Alliance over on the Western Slope. And we are interested in a lot of GIS application down at the zip code level. And I really like how you're trying to get individual address level data associated and from these types of efforts. I was really interested to know, with the use of R and the scripts that you use to be able to do that, do you have an example, or could you go back to that slide deck and pull up the example if I missed it, of how you were, the difference between the pre-R transformation that you did and the post transformation?
Yeah, I'll let you answer this, Julia. Is there a slide that you'd like me to share?
Probably the one where we formulate the key to match up on.
Let me just go back a bit.
Yeah, I will say we did consider performing matching on geocoding, and we do have all our addresses of priority interest geocoded, but with the way we receive patient addresses, there's typically a lot of like playing a game of telephone on data entry. And so kind of like with the examples of the differences between these addresses, they can get, just slightly one thing off could change how that ends up being geocoded, but, to our eyes, we're like, that's the same address. So with the kind of before the use of Postmaster, I will say this is very dependent on a zip code being present. If the zip code isn't there, it ends up not matching. We make sure that it is just the first 5 digits of that zip code, removing any kind of alphabetical letters that can end up being present sometimes in typos. And if it's not 5 characters, then we end up just setting it to null, and those don't end up matching. Kind of having to do some string regular expressions to take out apartment suite unit numbers from address 1 and moving it into address 2, choosing a proper case. But then with the Postmaster package, and Nicole, while I'm talking, would you mind dropping that link in the chat? Someone, what's the name of the package?
Yeah, can do.
It can parse out that street number, the street name, and then we just kind of concatenate all of that into one key. I hope that answers your question. I will say Postmaster is not on CRAN, so you do have to use the remotes package to install it into R.
Okay. When you're, this point number 2 under using Postmaster, when you say concatenate into a key, so would that be the separate kind of database that's created as the key that then is matched with these new entries that are generated? Maybe just get a better idea of this key.
Yeah, you pretty much have both data sets in your environment, and so patient, SpongeBob, for example, let's say he's living at this Chuck E. Cheese. He has his unique identifier and his name, and then he ends up with an address key looking like this 5156 Academy 80918, right? And then we have our list, our data frame of addresses that also get a key created for them. so that when we end up doing a left join, they will join on that key.
I gotcha. Yeah, that's helpful. I think I didn't understand that the left information on the slide was corresponding to that right information.
Oh, I'm so sorry.
Yeah.
But yeah, feel free to, Nicole and I can drop our email in the chat, and yeah, we can keep talking about this forever.
Thank you. Appreciate it.
Mhm.
I do see,
Oh yeah, go ahead.
yeah, I see another question in the chat, unless people have follow up on that, which is about our new surveillance system launching this fall. So at CDPHE, we do have, we've had CEDRS. It's been around since the 1990s. And so we're ready for, I think, what David talked about, that public health 3.0. And so we're working on a transition to a system called Epitrax, which is a consortium that other states have already started using. And it is an integrative response. It has an outbreak database system, a case database system, and also a contact tracing and investigation system. So it could also take over some of the pieces of our current data sharing portal. So it really is a one-stop shop, and all communicable diseases will be onboarded into it eventually. And so the idea is to have this table that we're using to match addresses live in a server, so that way it can consistently be matched day in and day out to cases that are coming through. So yeah.
All right, we have time for probably one more question. Does anyone have a question? All right. Well, yeah, feel free to maybe some things will percolate after today, and Julia and Nicole entered their emails into the chat. Thank you. With that, we have a 5-minute break before our next presentation. So definitely stand up, move around if you're able to do that. Get outside if you want to, get some sunshine in your eyeballs. And we'll come back here 10:53-ish, 10:52, 10:53. So see you in a little bit. All right, welcome back, everyone. We are going to get started with our second presentation titled Leveraging Technology to Achieve Equitable Outcomes in COVID-19 Cases. Sarah and Rebecca, I'm going to let you all take it away.
Good morning, everyone. We are going to be presenting on leveraging technology to achieve equitable outcomes in COVID-19 cases. I'm Sarah DeLong, and I'm going to be presenting with Rebecca Hermann, and we are epidemiologists at Boulder County Public Health. So looking at an overview of what we're going to be discussing, we're going to take a quick look at Boulder County demographics. We're going to look at our racial and ethnic disparities throughout the COVID-19 pandemic. We're going to discuss how we reached COVID-19 cases through a bulk texting approach. And Rebecca is going to discuss priority population case interviews, considerations and drawbacks to both of the programs, and takeaways and acknowledgements. So jumping into demographics, we do have a diverse population that has a variety of differing public health needs and risks. And these factors can vary due to our urban and rural divide, language diversity, as well as a variety of age groups. Our total population is around 330,000 people, and we are comprised of 10 unique incorporated towns and cities, as well as unincorporated areas. Looking at some of our race and ethnicity data, our Hispanic and Latina population made up 13.8% of Boulder County population, but at the start of the pandemic, it made up 51.9% of cases. And that is compared to white non-Hispanics, which were 77.6% of our population, but only 44.2% of the cases. So here is a age-adjusted rate ratio from the beginning of the pandemic. It is March 14th, 2020 through December 31st, 2020. And white non-Hispanics were used as a reference group and compared to BIPOC and Hispanic any race. So looking at BIPOC individuals, their case rate was actually lower at 0.81, but their hospitalizations and deaths were significantly higher. The deaths were almost over double deaths of white non-Hispanics. And then looking at Hispanic any race, the cases, hospitalizations, and deaths were significantly higher than white non-Hispanics, with hospitalizations at over 7 times higher than white non-Hispanics. So yeah, looking at the first 9 months of the pandemic, we noticed a huge disparity between these groups. And yeah, so looking at this, we did notice BIPOC had lower case rates, but their hospitalizations and deaths were higher, and then Hispanics and race were higher at all things. So looking at these stark racial and ethnic disparities, we did identify a need for public health intervention with a focus on uplifting these underserved and higher risk groups. So this began the bulk texting program. So we started this program on March 21st, 2022, after a cessation of universal case investigation following the Omicron surge, and also identifying case investigator burnout. So for this program, we utilize Google Voice as well as a bulk text extension to be able to send out all text through this extension rapidly. So the information of this message focuses on providing resources and knowledge, as well as a disease control focus. So we text every positive case, excluding cases that are in jail shelters, long-term care facilities, or whose lab results were over 10 days old. And these texts go out on every business day, Monday through Friday. And the goal of this project is to be able to reach some of these cases that we were having trouble reaching through traditional case investigation. That can include our monolingual Spanish speakers, immigrant and undocumented communities, those that live in rural mountain areas, older adults, people with underlying medical conditions who could be higher risk, as well as those living in a high CI area, people experiencing homelessness, as well as college students. So here is what the text looks like. We send every single text out in English and Spanish, and the text first goes into how we are able to provide resources, some of the resources that are available, and it gives some options about how the recipient is able to contact us. They're able to fill out a form that we call a WUFU form, and we'll go more into that shortly. They're also able to call the Boulder County Call Center, and it lists the number, the time, and the number that is available. And they're also encouraged to text back if they have any questions about isolation or if they are interested in therapeutics. And this number is monitored by an epi Monday through Friday at the times the texts are sent out, and they're also able to check the validity of the text. So looking at some of the data, since March 21st, 2022, we've texted 17,663 cases. We did identify 69 of those as monolingual Spanish speakers. However, we know that number is underreported and a little bit lower than the reality. And 1,784 with Hispanic or Latine, 880 were BIPOC, and white non-Hispanics were 11,777. And we did have a significant portion of cases that are unknown race or ethnicity at 3,302. We also took a look at the where people live, the city they lived in. So we did see a significant portion of our cases lived in the city of Boulder, as well as Longmont, Lafayette, and Louisville, but we were able to reach some of those more rural mountain communities, including Nederland, Niwot, Allens Park, and Hygiene, just to name a couple. And looking at some of the resource data. So the chart on the left identifies how many cases reached out directly to the resource navigation team through the text message. And we did see we had a peak in June, but that number did remain high through the end of the year as well. So going a little more into that WUFU form, the link that's included in the text, people are able to click on that form and select a box of what resource they would like. Here are the options listed. This can include food, shelter, rental or mortgage are some of the most popular ones, also utility, assistance, information on treatment. But we also do have another box that's just a blank box. So if the case does not find the need under any of the other categories, they're able to fill out their own request as well. And this form is available in English and Spanish. So some of the most common requests we got back from the text resources were the most common. So including calling the call center, filling out the form, a case is also able to just text the number back and ask for resources. And that information is shared directly with the resource navigation team. If a case asks for information on isolation, that question is answered directly by an epidemiologist, as well as information on therapeutics. We're able to share that information as an epidemiologist, as well as offering the case a phone call by a team member to help get more information and help access therapeutics. We also often got asked where to find home tests, and this information really varied throughout the pandemic, but we were able to provide options to pick up low or no cost tests. So the impact of the program, we believe a unique resource concentration allowed us to provide help and resources to more cases. This program also provides a quick, direct line of communication for cases to ask any questions they have to an epidemiologist. Through gathering the texting data, we can also identify higher risk patients who might be eligible for therapeutics and provide more information on those if they choose to access them. And we're also able to provide accurate and up-to-date public health information in multiple languages in a landscape that's ever evolving and changing to make sure the public stays up to date. And our main goal too is making resources available. So through this program, we're able to connect people with local organizations in Boulder County to assist with urgent needs. This can include access to food, rental assistance, and places to isolate. And assistance is available in English and Spanish, and we do have access to a language line to work with cases if they do not speak English or Spanish. And we also were really focused on therapeutics. So Boulder County actually does not have a test to treat site. So we made sure we worked to connect people with other options that were free or low cost. This included telehealth, pharmacy programs, as well as connections to local clinics. And now I'm going to turn it over to Rebecca.
Thanks, Sarah. So I'm going to discuss a program that we developed to supplement the bulk texting program, which were our priority population case investigations, or the PPCI program. And this utilized the skills of our experienced case investigators to reach out directly to the highest risk populations that we identified in Boulder County. And this really got its start because our surveillance team notified us that there was a concerningly high incidence of COVID among our 75 and up population who are not long-term care facility residents. And so in addition to wanting to get at the drivers behind why this incidence was increased, we also wanted to make sure that these folks, many of whom are at higher risk for severe disease from COVID, were getting the information and resources they needed to see them through their recovery. So this program developed and ultimately ended up replacing our general case investigation, which addresses folks who are not living in congregate settings or institutions. And it allowed us to focus our resources on the highest risk groups that we identified in Boulder County. So this program consists of resource-focused case investigations to populations that are either currently experiencing higher rates of COVID, who are at higher risk of severe disease due to COVID, or who may have less access to resources during the pandemic. And while this has shifted throughout the program, this has included populations such as those aged 50 and up, 65 and up, and 75 and up, monolingual Spanish speakers, those with certain underlying medical conditions, putting them at higher risk for severe disease from COVID, and those without insurance or who are on Medicaid or Medicare without supplemental insurance. So whether a case falls into these criteria to receive a call is determined via surveillance data and medical chart reviews that we conduct. And then the eligible cases are really easily filtered out, and our investigators can identify them in our EPI app, which is an app that was developed by our surveillance and informatics team, and it talks to CEDRS to directly import case data. So when our investigators reach out to these folks in this program, they'll do an abbreviated case interview. So they'll ask about symptoms, demographic information, and make sure we have up-to-date contact information for our cases. But rather than trying to collect data from cases, we're really focused on providing information to them, especially on isolation guidance. We've gotten feedback from cases that since isolation and quarantine guidance has shifted so many times throughout the pandemic, many of them don't even know what the guidance is when we call. So our investigators can really walk them through that timeline and make sure they understand how long they need to be at home. And then our investigators help them connect with resources and especially getting treatments and therapeutics. And we also help those cases locate free or low cost home test kits as well. And again, like Sarah mentioned, we don't have a test to treat site in Boulder County, unfortunately. So our case investigators were really trained up to promote the options that we do have, such as telehealth and other local programs. And they were able to provide a really comprehensive education to cases on the options that were available if they were interested in getting treatment. But we also noticed that many cases faced a barrier in accessing some of those resources and options. Even just having to sign up for one of those programs online can be really tricky. So our case investigators could help cases set up those appointments and walk them through that process as well. So in the time that this program has really gotten up and running since August of 2022, our investigators have made over 1,300 calls to priority population cases. 780 of those took place last year in 2022, and over 550 have taken place so far this year. Only 24 were identified as monolingual Spanish speakers in our data sources. And again, we think that represents some underrepresentation because anecdotally, we know that our investigators are speaking to folks in Spanish far more frequently than that. And overall, you'll see that the vast majority of these calls, over 1,200 of them, were made to folks aged 50 and older. And of that group, most calls were made to those aged 65 and up. So some of the benefits and impacts that we noticed from this priority populations program are that it's really flexible. And so we can adjust the populations that we target as needs change, as disease rates fluctuate, and other circumstances shift throughout the pandemic. We also noticed that our investigators are frequently reaching individuals who were completely unaware that some of these resources or treatment options even existed for them. So our investigators are really amazing, and they go above and beyond for our cases. We've had an investigator with cases permission go pick up their Paxlovid prescription at the pharmacy and drop it off on their porch because they weren't feeling up to driving. We've had investigators stay on the phone with cases for hours trying to get them the earliest possible telehealth appointment. So we know that even though this program is reaching only a fraction of the total cases that are reported in Boulder County, that personal service that our investigators are able to provide to some of the highest risk individuals in our community has a disproportionately large positive impact. We also do our very best to reach out early in cases' disease progression and encourage them to get evaluated by a provider right away if they're interested in treatment. And that can help ensure that they get seen and screened within that narrow window for treatment. And finally, this program really reduces barriers overall to accessing treatment, especially needing to sign up online or have access online to some of these resources. So when taken together, the bulk texting and the priority populations programs really strengthen the rapport between the community members of Boulder County and our public health department. And ultimately, this helped reduce disparities in those folks being able to access disease control guidance, therapeutics and treatments, home test kits, and other vital resources.
So looking at some considerations and drawbacks, it was a really large amount of data that we were working with, and that amount of data was difficult to manage in programs such as Excel, which we use to track cases. And preparing text to get sent can be time intensive depending on how many cases needed to be texted throughout the day. And it also does require active monitoring throughout the day. And we do typically receive a small number of responses compared to the amount of text we send out, and that can make it difficult to quantify how many cases benefit from the information in the text. As well, the program does occasionally receive negative responses back. And we do know that those with landlines receive the message as a voicemail read in an automated voice, and that automated voice does not speak Spanish very well. So it can be a little bit hard to understand if someone was a Spanish speaker listening to that voicemail. And we do only contact lab tested cases, which does exclude those that test positive on home tests. And it can be difficult to obtain outcome data due to the limited resources to follow up with individuals who have received the text or been called by the priority population program.
So our takeaways from both of these programs are that, of course, existing racial and ethnic disparities were then severely exacerbated by the pandemic. So for us as public health workers, it's key to collect and analyze race, ethnicity, and other demographic data on the front end so that we can identify where the needs are in our community, and then make sure that we're putting health and racial equity at the forefront of all programs and interventions that we develop. So for us, a bulk texting program was one way to ensure that diverse populations in our county were able to receive equal access to information on disease control and resources with relatively little time and effort required from public health employees. Being able to then focus the language within those texts on the resources that are available in a community can make those programs accessible to individuals who need them, but who may have not even been aware that options existed to help them. And finally, a universal bulk texting program allowed us to really focus our case investigations on the highest risk populations in our community. And this ended up being far more efficient for case investigators' time and mental health. And it was more effective at reaching those who not only would have the greatest benefit from public health intervention, but also who were most open to receiving our help. So that takes us to the end of what we had for you today. Thank you so much for listening to our presentation. And we also would love to acknowledge Steffi Goodman from our surveillance team, who I believe is on the call, and Fabiola Hernandez from our resource navigation team. They provided data that made this presentation possible, so thank you so much. And we could not have this program without our case investigators, Gabby, Cindy, Griselda, Debbie, and Kathy, and our resource navigators, Julia and Lucia, who help connect those cases to critical resources. Yeah, thank you so much, and we'll take any questions you have.
I'll highlight the question in the chat that was already answered, and then there's some other ones in the chat, but Mike asked if the app you mentioned that was developed for internal use or available to other entities. Steffi is on here, and she answered that the application is a database management system you developed for Boulder County COVID case management with assistance from your county IT partners. Good question. And then you have two other questions in the chat. I don't know if they go together, but which bulk texting program platform did you use? And for the bulk texting, did you get client cases, feedback, and data numbers?
So we used a Google Voice, and there is an extension. It's a free extension available on GitHub that we used. I'm happy to share a link to that in the chat if others would be interested. Can do, Mike.
Yeah, and in terms of getting feedback, we do receive texts back from folks. We have gotten some feedback from that, but mostly it's people asking questions. And unfortunately, you know, that's kind of maybe a lofty goal or want from this program, is we would love to be able to reach back out and kind of measure outcomes better, and see how the information in those texts was received, if it was helpful. Unfortunately, it's I think a lot of folks on this call are probably familiar with, it's hard to during a pandemic be able to have the resources to follow up with that amount of data, that amount of folks that we reached out to. So that's something that we would love to do in the future, and would be great if other folks are considering implementing something similar, trying to build into a program, if you have the resources for it.
Any other questions?
I have a quick question. First off, hats off. This is an incredible program. But also, do you find sort of just in working with CICT staff that this texting program was assistive in terms of resiliency and in the way that they interacted with the public?
I would say so, yes. We do get messages back regularly that was like, wow, we really appreciate that Boulder County offers this and is be able to connect with that. So I do think it helps improve our reputation with the public.
Yeah, and I would say that, you know, the priority populations that we then have our CICT staff reach out to have been, I would say the feedback we've gotten has been has been happier with us than with the general public case investigation that we were doing before. And I think our CICT staff just feels like they're really, really helping where help is needed, and really making sure that we're impacting folks who actually want to talk with us. And that, I think, has been great for their resiliency, mental health, because that's something that we've definitely struggled with throughout the pandemic.
Other questions, thoughts?
Yeah, so when developing the program at the time, it's where a lot of our data was held. It was me who picked that, and I choose to import it in there first so we could organize it and clean the data. We wanted to make sure we weren't texting the cases that we wanted to exclude, like the long-term care cases, and it was easy to do that through filtering on Excel. But if I was doing this program over, honestly, I might choose a different platform in the future when it did start to get really large amounts of data. What platform would I choose? That's a good question. I think maybe even adding something into our Epi app, our internal app would be great. Having more data analysis in something like R, I think would be really beneficial too. Thank you.
We have time for one more question. Does anyone have? Well, thank you to all of our presenters, Rebecca, Sarah, Nicole, and Jules. These were really great examples of some really great data that you all have and the efforts that you're doing to break down some silos that we have within our public health systems. And thank you all as audience members for attending this session. A few short announcements to close out. So slides and handouts will be available. They're on Schedule. You'll receive a conference evaluation via email once the conference is over. That's today. So please fill that out, even if you only attended this session or just a little bit of the conference. It really helps us on the planning committee and other folks on the planning committee think through what went well, what we can change and modify and evolve for next year. And there's a raffle for everyone who completes the survey within 2 weeks. And it's a raffle for 2 $50 gift cards. All right, so this is the end of the last live session of the conference. There is a walk and talk session after this on equity and a career advancement in academic medicine. You can take a walk if you want to listen to that. And after that, the conference will be over. Public Health in the Rockies is the other conference that the Colorado Public Health Association puts on. That will be in September this year. And thanks for supporting us at CPHA and joining these sessions and supporting our speakers as well. Have a wonderful weekend. Happy Friday, everyone. And thanks for coming.